Okay, hi everybody. This is Misty Delgado from Relivar Home Care and Livity Care Advocates. We're excited to do one of our sessions, our Facebook Live sessions. So thank you so much for our Facebook Live folks that want to come on and learn about palliative care and hospice care today. With me, I have Krista Rolando, and she's our administrator from Relivar and Livity. And then we also have Angela Green, and she is from Hospice of Michigan, and they have a palliative care company as well, and she'll explain that a little bit later on. But I do want to take a minute and just explain to you, help you understand why we're doing these sessions. We provide private duty home care, and we also provide advocacy care. And a lot of times when we're working with family members or working with someone who's struggling with a decision, they're coming to us trying to figure out what to do and how to do it. And we have found and worked with many resources and companies in the Detroit metro market that we find to be huge value and reliable and good quality staffing. And so we're here today to and going forward to help educate you on different things and resources that we've found that are good. And so you're kind of getting in on some of our education that we've learned in the streets from doing home care and advocacy work. So Angela, I'm gonna kind of turn things over to you. It is more of a collaborative session just to talk about what is hospice, what is palliative care, and let's talk about when families should consider this.
Sure, absolutely. First, thanks for inviting us today. It is huge need in our communities to get word out what the two programs are, because there's so many mistruths and confusions about the care that really is there for people and their families. It's a whole. Neither program is about one person. Of course, it's about the person with the terminal illness, but it's also about that whole family that has to be hugged and taken care of. So thank you.
Yeah.
Let's start right with hospice, the harder of the two, of course, to talk about. Hospice is a Medicare benefit. That's a really important thing to always remember. Your whole life, as you've worked, you've put your money in towards your Social Security, and eventually one day you got your Medicare. But they took hospice, wrapped it up, and said, every person can have it, and it should not cost them something, except, of course, if you have your deductible. Mm-hmm. So while it's covered, we always still hear people back away thinking they can't have it. We want to break that process. It's there for everybody. Okay.
So question on that, if I can break in a little bit, because I know a lot of times we're dealing with the elderly folks and, they're on Medicare, but what about folks that aren't on Medicare?
Yep. Great question. Most of your other insurances, your Blue Crosses, HAP, Aetna, most of the policies will have a hospice part on there, a rider, but if you're not sure if yours does, you can always reach out early just to see the what if, because each one is different. And you will see there are hospice companies who will only have a list of certain non-Medicare companies that they can provide for. And that is, I will point out one difference between a for-profit and not-for-profit. A not-for-profit, they will take your insurance regardless of whose it is. And that's always something to keep in mind.
So what you're saying is out there today, because most people don't know this, you've got for-profit hospice companies, because I know the industry's grown tenfold since we started in business.
Oh, yes.
And then you got some for-profit and some not-for-profit. And I think Hospice of Michigan is a not-for-profit.
Absolutely, we are. Yeah.
Okay.
And that allows us, you're not-for-profit, it allows us to take, at the end of the day, how much of every dollar we are spending on patient care. That gap is incredibly large between the for-profit and the not-for-profit, but also it allows us to take in the person who either has an insurance, nobody else is, or they simply have no insurance at all. As long
Okay.
as long as there is a terminal illness and a need for the care, they're not going to be told no.
Okay. All right. That's great. Thank you.
Yeah.
Yeah, I did not know that.
Yeah, it's a large part of being able to, you have to provide care where it's needed.
Yeah.
Yeah, we like that. So after we get through the Medicare part of outlining the program, the biggest part is, of course, you have to have a terminal illness. And when I sit with people in the community all the time, I tell them, Medicare has set forth the guideline of 6 months of expected life in front of the person. But that's based on a textbook disease process. By no means is there a calendar that has 6 months on it with a date circled, and that if you're still here, you're off hospice. It doesn't work like that. How it will happen is once you are onto hospice, then going forward, they have to prove there is a decline. Doesn't have to be the biggest decline, but there is some decline. And that's what allows people to be on hospice for a year, 2 years, 3 years, 4 years, and some even more. Yeah, they're not getting better. It's just they are declining at a much slower rate than the textbook said they should.
So who determines that?
That's determined between their hospice nurse and then the hospice physician.
Okay.
So, they're always paying attention to, of course, their weight, pain. Pain is generally a very large part of hospice for many people. We may be following their decline in being able, are they speaking still? What's going on there? So it's a whole picture of changes in that person.
Yeah.
Okay. So at that time, what we do is what we call recert. The physician says, yes, they're still declining, so they may stay on, and that's how Medicare set it up to go on. Now, there, of course, are those people who, when you're following them, with all that extra care all of a sudden coming to them, and the stress and burden taken off of them and having to worry about going back and forth to the doctors anymore or hospitals, we start to see them gain weight. They're starting to get up more, enjoying more of their meals, communicating more with people, getting out of the house, and then they graduate off service, which that's a beautiful day.
Right.
That is a great day, and it happens. So we always tell people it's there, and that's okay. You can go on and off hospice as many times as needed. There is no limit. People worry about that. If I get on now, what if I can't have it later? No, there's no limit of coming and going.
Yeah, somebody, I think it was someone told me that if one of my clients goes to the hospital, they would come off. But then, if she wanted to get back on it, when she went back home, she could get back on.
Right. And it determines why somebody goes to the hospital. If we have a person on hospice and they go into a pain crisis, and pain is the number one thing that hospice is best at treating. And if we still cannot control that pain to an acceptable amount at home, we will admit them to a hospital.
Okay.
And we have hospitals we have contracts with so that your hospice nurse can still go in every day to see you. So there is some form of continuity of care, a familiar face that you've built trust with.
That's great, because hospitals are scary.
They are very intimidating, and especially if they've given all their trust to this one person, and now you're having all these strangers tell you what to do differently. It's overwhelming.
Yeah.
It's a hard. So in that situation, the person, if they're in a hospital we can work with, they do not have to sign off. It's part of hospice. And then once we have it controlled, we simply bring them back home. But if you do have somebody, if there's a fall at home and they have to go to the ER or need surgery, then they would sign off. Your hospice team calls the hospital daily, checks in with the case managers to see how you are doing and to help then with the discharge home, and then hospice can start again right away. Okay. A big part of hospice part that families and people have a hard time with is when when you're going through a terminal illness, we get aggressive treatment, and that is especially in the cancer field. You're going for your chemo and your radiation. Once you decide you want to go hospice, you stop that treatment. Now, I will say it's a little gray, especially in cancer for radiation treatments, because there are some situations where radiation is necessary to continue to give somebody comfort and quality, especially when we're talking about a mass that's blocking the airway. We're not going to just keep letting that grow.
Right.
We'll do radiation just to keep it down so that you can keep that airway open as long as we can. So that we would not stop. But your chemos, yes, they are stopped. So when we say aggressive treatment, they choose at that point, they're not going to go into the ER anymore they may feel dehydrated, any other reason. These are things we would take care of at home. A hospice company can. They're not going to go to the specialist anymore. No more cardiologist, neurologist. They're going to now let hospice oversee their whole care. And part of that is when they're at home, we're no longer starting IVs. We're not poking. It's all about comfort and quality at that point. And medications, and we're so used to, you're going to need an IV for that. You're going to need an injection for that. Medications come in such a variety now that your team can still take great care of you by using drops in the mouth under your tongue so they don't have to swallow. They're absorbed right through. We can do patches, creams. So there is multiple ways to still get your medication. We want you comfortable and to have that quality, but without having to put you through looking for that IV access again.
I have to tell you, that is so good to hear, because I remember one time we had a client years ago on hospice, and we were trying to give her pill, and we had it spit back out at us like 4 times. It became comical after a while, but
Yeah,
it's so good to hear that now, and those creams work fantastic, and
they do.
the drops do. So that's great.
Yeah. And by time we see someone come to hospice, generally they've already gone through the process of, spitting the pill out, the family having to smush them and put them in applesauce.
Yeah.
It works for a little while, but then they get smart to what you're doing, and they don't want applesauce anymore or pudding.
That's right.
There needed to be some changes made for those situations, and I think the pharmaceutical companies have made tremendous strides in that.
Yeah.
People. Yeah.
Well, one thing you said was that you have a relationship with some of the hospitals. So one of the questions that I have is, I've dealt with some people that are afraid to go home after they're in the hospital. They're, probably, what we call actively dying, and they don't want to go home.
Yeah.
Is there a situation where they could stay inpatient at the hospital under your hospice?
There are.
Okay.
There's a Western medicine. We're very good at, somebody becomes sick, we take them to the hospital, and as I kind of do a little smirk about, we all make chicken noodle soup for everybody. That's just what we do. We take care of them. Unfortunately, fortunately, when somebody is getting ready to become active, they could be pre-active or active. Those aren't the things that are going to make a difference at that point. The body knows what it needs to do to prepare itself for the final stages to pass.
Right.
And it can do it on its own. It always has. It's the opposite of birth, really. We're reversing birth at that point. When we talk about an inpatient hospice, we have to prove to the insurance company there's one symptom we absolutely cannot control at home. That's very difficult to prove, because hospice now has come so far. All of us are very good at being able to control those symptoms at home, but you will at times have crises that they cannot be. So then we do what we call a GIP. It's an inpatient status in a hospital. And as long as that symptom's still there and they're controlling it, you can stay there, and your hospice team will come in each day to see you, and they work with your hospital care team as they're moving forward with it. But it's such a low number of people that's really required for. What we see more is when somebody is in the hospital and they're told it's time to talk about hospice, and they agree. But then, as Misty said, that thought of going home with all of that help, it scares them. It scares the family. How are we going to do this? I can't do this at home. And that's when we jump in with education. That's when our social workers will sit down with them. Our chaplain will sit down with them. For many, it's also that part of the picture. And then, of course, that's where we start talking about bringing in home care and caregivers, because they need that extra set of hands on. It's a lot for a family. So we'll do that to bring that person home safely.
Right.
Yeah.
So how do so many times I get the question from folks that, or the person that, I don't want to die. I don't, if I'm going on hospice,
Yeah,
that means I'm going to die.
Right.
yeah. I wish there was one conversation we could have at that point, but of course there's not, because everybody has their different reasons. Some, they have a large change in their family coming up. It may be the very first great grandchild or the first grandchild. And unfortunately for some, it's the birth of their first child they're going to miss.
Okay.
That's a conversation that does take a whole team to support with that person and their family. It's not a one-time thing. It will occur numerous times and in different languages, because I think we all communicate differently.
Sure.
Sometimes it's finding which person in the team that they're connecting best with for what they need, and that's the person then who will lead it, regardless of what their title is.
Mhm.
It's important. I definitely many years ago, I can recall a situation like that, and unfortunately, there was never acceptance.
Mhm.
And that those are the hardest ones to watch, because then you never achieve true comfort.
Yeah.
or quality of an end story. But we work at I think every hospice worker, that is a situation, we will use any tools in our toolbox we can to figure out what their fear is, to try to work through with them.
Got it.
That's good that they have that.
Yeah, and I think that's why hospice is a team. I think that is a good part. Bring that in with your hospice. Once you're on hospice, you get a hospice physician. You have your nurse who will be with you going forward. She's the one who visits you every week or more when you're needed. You have a health aide who comes in your home, who can help bathe you, any of your personal care. And then you have a social worker who's there to help support that person and their whole family. And then the chaplain. So it takes that whole team to work with somebody. And then also volunteers in hospice are very important. There are people in our communities, all walk of life. I've seen physicians, nurses, professors, teachers, plumbers, every field. And they do great work with this person and their families. It can be something as simple as, I need an hour a week to go sit at the local diner just to have me time. Not a problem.
Right.
It can be, mom always had animals and we don't anymore. Wonderful. We're going to bring in one of our dogs. It can be, I used to play checkers with my brothers when I was young. I'd really love to play a game of checkers. I promise there's a volunteer out there who will gladly come play checkers with you. Sports fans, I need someone to watch the Tigers game with me. My kids don't get it. Oh, we got Tigers fans, don't worry. They play a non-clinical role, which I also think is really important for this person, because they're well aware they're sick. Even if they don't verbalize it, they know where the journey's going. This is an opportunity to spend time with someone who they don't want to talk about their medical journey. They have no input on it. They don't have questions. They truly want to be there just for you. And they need that reminder and that time to allow to be just them.
That's
Still
great.
have a life, still
Absolutely.
living.
Yeah. Yes. You should still be living till that last breath.
Right.
Yeah. And that would be hard for family to do sometimes. So it's good that you have the volunteers, because families are going to be more worried about, their family member and what's happening, and maybe forget about some of those other things that family member might need. So that's really cool to have volunteers that do that.
Yeah. And I think the volunteer also becomes very important to the family too, like I said, because they build trust and an actual friendship.
Yeah.
Which they need. It's not somebody calling to do the I'm so sorry or how are you doing? Nope, it's not about that.
Right.
We're doing something fun. We're doing something that everybody likes here. I think gives them all a chance to just kind of reset the mindset for that time period, to be just in that moment, enjoy each other's company.
Yeah, that's great.
Okay. And then hospice, when somebody does pass, hospice does not just leave that family. At that point, our bereavement departments jump in, where they offer counseling for that family, and that's part of hospice. It's not a charge. It can be in person, Zoom, telephone, whatever's easiest for you, however much you need. And Medicare tells hospice companies that we have to provide that care for 13 months. That's not to say in 24 months, when you're grocery shopping and you smell mom's favorite food being cooked, it doesn't mean you can't call and they're not going to talk to you that day. They're going to. We don't have a calendar. We don't keep a calendar on dates. So I think that's really important too. And for all families, because a lot of times right after somebody passes, a family's very busy. They have people all around, things are going on. They're not mourning yet. That grief isn't quite there yet because they're so busy still with everything. It's down the road where they need somebody to listen, somebody to help walk them through it the best we can. So I think people forget hospice is about the whole unit.
Angela, I know because I've dealt with many different hospice agencies, and I don't know who's for profit or not I knew you guys were not for profit, but I would say one of the things that I really like about Hospice of Michigan, and you guys are definitely one of my go-tos, is that you're always staffed up. I've had other, like a family will choose another agency without asking or, asking for recommendations. And then they're frustrated because they don't have somebody to come in and bathe them, or they don't have volunteers, and a lot of times if they don't have that staffing level or a social worker, then they'll just opt not to have that conversation during the intake meeting. But I've always found, because Hospice of Michigan has stayed kind of like in your own wheelhouse, you guys, that's what you do, and you do it really well.
Thank you.
Yeah.
I think the fact that we are the oldest hospice in the state, the not-for-profits, we've been here end of the 70s, early 80s, started in the city of Detroit by a group of volunteers. They saw a need, said, hey, we need to do something about this. And they did. And we've only continued to grow, of course. We only service from the Mackinac Bridge down to the border of Ohio. So our roots are very deep in our communities. We have offices throughout the whole state. So there are always physical places too. People can stop in if they need to, or your teams are coming out of. And because I think of our longevity and being always Michigan ran, that's attractive to a lot of us as employees. I know for myself, I'm retired out of a local hospital system. I thought medical career, we're going to close that chapter, and what are we going to do next? But when I saw this opportunity, it was a no-brainer. Being in a hospital, I've seen many, many different companies and spoken to many all through those years. But the one thing I knew about Hospice of Michigan is they told us, and I watch them do it every day, we go where we're needed. We serve our communities. We serve the people we stand in line at Kroger's next to. We serve our neighbors. We serve our friends and our families. And because of that, that always makes you every day bring your best to the table because you know that person in front of you.
Mm-hmm. No, that's great.
Oh, yeah.
Well, and you guys have a good reputation, you know.
We work hard for it. We'll continue to.
Hospice is some of the hardest, business, to be in because it can be so short term and always dealing with death. I know on our home care side of things, some of the caregivers after their client passes, they do, they need to take time off because they've gotten so close. It doesn't matter whether it was 3 days or 2 weeks.
Yeah.
It really starts to uncover and peel back some of their grief that they've had, in their lives, or whether it's going on currently or happened in the past.
Right.
Definitely. And I think especially for the caregivers, they are there. And I say it for our home health aides. They're generally there with them more often. They really, their relationship becomes much more intimate. Of course, you're going to grieve and it's going to hurt.
Yeah.
But that's where hospice also is there for it's not just for the patient's family, but it is also for all those who've cared for them and loved them. From our workers to your staff, the grief counselors are always available. They're there. And as for those of us who do this every day, especially long-term, yes, you'll meet somebody every so often who, for some reason, you click. They leave a huge impression on you. There's days we go back to our car and we cry too.
Yeah.
There are definitely. And we try to always remind ourselves, we have to be able to move forward so we can help many. Otherwise, we're really not doing our job well.
Right.
So to do that, we talk a lot between each other. Our grief counselor and our chaplain are critical to us because we call them too at times during the day when, hey, I need a reminder again, help. And they're great at it. We plan activities outside of hospice to remind us to laugh and to keep focus on all the good that's going on out in our communities. And that's part of it. You can't let yourself sit in it. You've got to get out, take that walk around your neighborhood, look at all the great things happening. And that's how every day we're able to keep coming back and doing it again.
Yeah. Oh, that's great. If we can go back to the criteria, one more time, because I know a lot of families are like, well, first of all, I think there's a lot of families, individuals that would qualify and it just doesn't occur to them.
Sure.
So, and I know a lot of times hospice coming in, they have typically supplied beds and briefs and so many things that can take the financial burden off of that person's illness. So if we could just go back to that criteria, like if you were a family member and you had a loved one that was, aging and not doing well, what kind of process or steps would you recommend that they take to see if they would qualify?
Once you have a feeling, if your loved one, if they've been in and out of the hospital multiple times in last 6 months, you've had 3-4 hospital stays. They've had a weight loss. A good amount of weight has been lost. They're no longer able to dress themselves, feed themselves, incontinence. We're looking for those, your everyday activities. But then let's look at the disease processes. You have somebody going to dialysis every day who says, I don't want to do it anymore. They need hospice then. A cancer patient, either your oncologist will say, we've used everything we can, I'm sorry. Or simply somebody who earlier than that says, I don't want to keep doing this. I'm sicker from the treatment than the cancer. I want to spend what time I have left in a better position to enjoy my family. That's when to call hospice. I encourage you, if even just when you start to think she's not doing as well, she's not up and about her usual self anymore. We're having to go to the doctors more often. We've had to go to the emergency room. Call a hospice. Because at that point, we will call your physician. We get medical records, we review them, and we'll send out an admission nurse who will let you know right at that visit, yes or no. If yes, she will admit you and you start hospice. But if you're not quite ready, she will tell you why and what they're looking for. And at that point, we don't just close the door on you. For our company at that point, we would look at our palliative program for you, or our navigation program, where somebody like me, I am calling you. What it may be every 2 weeks, it may be every month. We decide that after we speak the first time. And I'm going to give you community resources that I know you're looking for. It may be a caregiver. It may be a home care nurse at this moment you need, but we will help find those in your area to set you up, and we'll still keep though in contact as we're following you. Okay. So any disease process where we know we're expecting about a 6-month life expectancy on paper. And with hospice, the benefit does cover, just like Misty said, the equipment, all your hospital bed, your wheelchair, a bedside commode, oxygen, any durable medical equipment, that is covered 100% under hospice. Briefs, if somebody is incontinent, hospice will cover those briefs for them also. And then medications, all medications that are ordered from hospice for their diagnosis, those are covered 100% and are delivered right to your home. So you don't have to go wait in that long line at Walgreens or CVS right now. They're
Right.
there for you. Yeah, so it is that whole package.
Okay. All right. So basically you're saying, if you're seeing a decline and you're unsure, to call, because an assessment can be done to determine whether they qualify or not.
Yes.
Yeah.
And it gives us the opportunity to jump in a little sooner to help you prepare for that day, but also let's look for those resources you didn't know that were out there that could make today better for you. Let's work together.
Right.
Great.
So one of the things I hear from family members too is, or, even the client themselves is, well, I have to give up my doctor.
Yeah, that is a big one. Once you go into hospice, you do not have to give up your primary care physician. All of your specialist that you were seeing for your disease that had ended in hospice, yes, but not, you could have your primary care physician stay on to oversee your hospice. What time has taught me though is many times when we approach your physician to ask them, they will say to us, I would love to. I would love to do that, but I don't think I should. The reason they say that is because a hospice physician for our company, when we call them, if they do not answer us immediately, they have 10 minutes to call us back. And if they don't, then we call their boss.
Oh. Wow.
Okay. The reason being, you have somebody with a terminal illness. Their emergent needs don't wait till tomorrow. They cannot wait till tomorrow. A pain crisis cannot wait till tomorrow. It has to be addressed now. And our physicians, they only work for us at Hospice of Michigan. They do not have practices. They do not work as hospitalists. They do not go in nursing homes. They only work for Hospice of Michigan. So they have nothing else they need to do other than support our patients.
They're like that appliance guy sitting by the phone waiting for it to ring. Right?
Yes, really, it is. Yes, and we take the state and we divide it into areas, and each of those areas has their own physician over it. And then, of course, the physicians all cover each other too, because they do have to have time to sleep and a day off.
Sure. Yeah.
So and when we have that situation, because people do, the more you're at the doctor's office, the more that relationship becomes tighter and more important to them. So I'll tell people who come in my area, I'll tell them, if you want, if yours says no, thank you, don't worry. I will keep them updated. I will give them, whether it's a monthly or if things are moving fast, a weekly update on how you are doing. We will keep them in the loop. And that makes a lot of people feel better about it, because they've built trust with that person. And the physicians thank us too, because they do want to know, they do care. And like us, when someone passes, they grieve too, and they mourn the loss of their person.
Sure.
Yeah.
Well, I do have a recent experience with that because I have a lady that I advocate for at a community, memory care community. And originally her DPOA wanted to keep her with her primary care physician. And I had been asking, because she had edema in her legs and feet, and they were just getting bigger and bigger. And I'd asked that doctor multiple times, well, you know, what are we going to do about this? Now they're turning red. And so she's on hospice, but the primary is overseeing it. And then finally, the hospice agency stepped in and said, our doctor is going to oversee things from going forward. And immediately they came up with a solution for the edema, you know, because there's this balance of they want to get rid of the excess water, but they don't want to dehydrate her at the same time. So they had an answer for it. They, gave her medication to deal with the edema and gave her potassium pills to help with the dehydration. And we've had no issues. And, the swelling's come down. And, it's unfortunate that her own primary care physician, because we've been dealing with this for over a year now, but I was so happy to see that really occur, find a solution to that.
Yeah, it's hard, when families, sometimes they will be upset when their physician says, no, thank you. Or when they say, yes, I'll do it in a situation like that. And I tell them, please keep in mind, when you call the doctor's office lately and you ask for an appointment, how far out is your doctor booking? Our doctors are so overwhelmed. They're one person and their practice is they're all so large.
That is right.
So it's really, and they would love to be able to do all that for everybody, but they can't. They're one person. So we have to really put in perspective the caseload everybody's carrying. Let your hospice doctor, if yours cannot do it for you, a hospice physician, that's what they're trained in school for, is hospice care. Hospice care is different.
Absolutely.
Than regular care.
Right.
We're focusing always on quality and comfort. And we do things a little different. So take advantage of that knowledge.
I think from a medication perspective too, Krista, do you want to tell the story of that client that we had that fell down, dementia client that fell down the stairs? And they put her on hospice?
Yeah, absolutely. So we had a client that we were taking care of for quite a while, and she obviously has dementia, and there were some safety concerns in her home, and she ended up wandering, and I think it was in the middle of the night, right, Misty? That she kind of wandered.
With her husband was sleeping, yes.
Yeah. And she fell down the stairs and had back fractures, several back fractures. And her husband had been in the medical field, and so he knew quite a bit about things that were going on. But instead of doing surgery and putting her on these medications, they went through and put her on hospice. And so many people questioned it at the time, but it ended up being the best thing for her because she healed appropriately and comfortably, and and she's doing really good now and not on hospice anymore. So
we love those.
Yeah. So making that decision, and I don't think that's something that I would have thought of, at that time, not knowing what we know now about hospice and those kind of situations.
Yeah.
But I mean, what a difference that it made in her life and his life, because he didn't have to worry so much about her being in the hospital with dementia. That's a big thing for people, I mean, they're taken out of their home and put in a place where it's just, it's scary for them. They don't understand. And then they're having medications messed with, and it's just not proper healing for somebody with a dementia diagnosis. So it ended up being a really good thing for her.
Good. And dementia is a hard one for hospice. I'm not going to say it to the date, but about 10, maybe 10 years ago, Medicare came out and said that's no longer going to be an acceptable diagnosis by itself early on.
Yeah.
So we said, okay, define for us, when is it appropriate? And it came back to at the point where they're bedridden, they're not speaking anymore. They might have one word here or there, can't feed themselves. That's when they can come to hospice. Well, we know by the time somebody gets to that point, that family's beyond exhausted.
Mhm.
That can be, for some people, that can be 10, 15-year journey before they
Yeah.
get there. You
That's
know,
right.
so not helping the person or the family. So a lot of times with people, when we get that call where mom has dementia, she's getting up at night, we've caught her at the door, she's tripped already, left the stove on, we just don't know what to do. We already know at that point, dementia is not going to be the key here. But let's talk more about mom. Tell me what else about her. Let's talk about her weight. Let's talk, how's the cardiology? Has she, does she have a cardiologist? How is her heart health?
Right.
Okay, let's talk about her lungs. We want to get all of the pieces of her puzzle in medicine and put that together, because many times it's all those comorbidities that will actually qualify her for hospice. It's not always just a very obvious, mom now has stage 4 cancer.
Right.
It doesn't have to be that obvious. It takes a little work, but that's okay. Let us do that legwork for you. Sometimes we'll put that whole puzzle together and find out we just need one more piece. And again, we stay involved, we stay in communication with you, and we keep looking for that piece.
Mhm.
I think that's really important for all of our people out there with dementia, because that is a battle that can be such a lengthy one for those families. They need all of our resources.
Right.
Yeah.
Well, do you want to move on to palliative care? We've talked a lot about hospice today.
Yes, palliative.
If we don't, we're not going to get to it. We only have about 10 minutes
Yes,
left. So
let's do palliative. Palliative's become a buzzword in the last few years out in all of the communities. The biggest difference I want to have people take away from this is, where hospice is a Medicare benefit, it is very well defined exactly who and who cannot use that service and what that service must include. Palliative has no true set Medicare definition or program. So there are many things labeled palliative, and they are all drastically different. So please, when you're considering palliative, reach out to a couple different if you need to, because they're all going to come back with a very different picture for you. And you need to find the one that fits your needs best, of course. Because we are a hospice company, and that is what we will always focus on. We've determined we want a program that somebody has approximately 6 to 24 months of life expectancy left. Again, we're not setting a hard calendar down. That's just a guideline. We're looking for somebody, they may be going through chemo and radiation for cancer, but it's all the symptoms that keep them going back to the ER. So that's delaying their actual treatments with their oncologist. So then the oncologist has to deal with those and can't move forward. That is an ideal person for palliative, because your palliative physician and nurse practitioner will jump in and they will only focus on that nausea and vomiting, that pain that they cannot control. Let them jump on those, focus, because again, because they are hospice based, those are the things they do best, is symptom management. That allows your oncologist to focus solely on the disease process itself and work on that. And it helps keep you out of that hospital a little more, which I think everybody appreciates. It can be used for a person, COPD, somebody receiving dialysis, but they still need more help with those symptoms at home. So there's many different situations going on. Some will be your Alzheimer's and your dementia patients, of course. But the biggest thing is it's all about that symptom management, which can be pain, nausea and vomiting, anxiety, which increases with all of the medical issues, depression. They're not eating anymore. We can work on that appetite. Okay, so again, just like hospice, you want to call into a palliative program sooner because it gives them somewhere to start from, and it also helps us guide you better. With palliative, you have our physician and our nurse practitioner. It's not an emergent service like hospice, so they're working 8 to 5 Monday through Friday. You're still utilizing your physician and all your other care teams. You can still get physical therapy, occupational therapy. You're still going in and out of the hospital whenever you need. We're just jumping in to join all of those other groups of people. We're not taking on all of your care. And that's really important because people will call us at midnight. Pain's not under control, it's not working. Unfortunately, palliative, they don't work 24 hours a day like hospice does. So you always want to keep that in mind. And we're watching to see the changes in them. And I think it gives us an opportunity too to work with those families to help prepare them for what the next steps will look like before they get there, which makes it a little less scary for them also.
Mhm.
So if I have a loved one, you know, because you have the two lines of business, palliative and the hospice care, do you guys look at the situation and evaluate whether it would be palliative or hospice when you come in to do the assessment?
What will happen, many times people are usually pretty specific about which they want, but both programs will automatically, when they come in, they are looking to see if the other is a fit. Yes.
Okay.
And I think with palliative, we see more, you see it more often with palliative patients. When they call and we go see them, it will be very obvious to the nurse practitioner right away. They really need hospice. They need more. But many times they're not ready. The family's not ready. That's okay. We'll keep them on palliative, but that becomes part of her care plan with that family, is to help educate them and guide them over to hospice. Many times that does happen. Sometimes somebody will never be ready to say the word hospice. They will stay on palliative and pass on it. And that's okay. That's where they're at.
Got it. So if you were, you know, because you're very familiar with hospice, if you were a family member kind of deciding, because there's so many out there right now, what do you look for? What do you ask? How do you know to decide which company to go with?
I'm going to look, I do want to look at that not-for-profit and for-profit part, because your not-for-profits, they do put more of that dollar back into their patient care, and more patient care from my loved one is the biggest win right there. I'm also going to look at longevity. With any medical company, we know they're extremely competitive. We know they're growing and popping up everywhere all the time. For a company that can make it a marathon instead of a sprint, that tells you a lot about their quality of care, their reputation, and what they put in to stay where they're at. So I want to know I have a company that is strong and backed.
Are you saying like a company that's been in business for a long time?
Yes.
Okay.
Yep. I'd like to know I have a company that is what they know. That is what they truly do, is fully hospice. I'm a little leery when I also know they own all different other fields, because it tells me they're not putting all their resources in one. And when it comes to end of life care, I want somebody who they're the top at it. That's all they do. I think that gives me a better chance for care. And I am going to ask word of mouth. You can't beat word of mouth. Even though we've been in the community as long as we have, we definitely keep reports where all of our referrals come from. And family and friends is always the #1 resource. always. You know, we have many families, we're on third, fourth generation of providing their hospice for. When a family trusts you that much, you can't beat that. So I would ask your neighbors, ask your coworkers, ask your friends. I see it all the time on my own Facebook page. People will pop up, hey, do you know? You know, ask around. People have no problem telling you we know anymore. When they don't like something, they like to share that. So
Right.
ask the opposite question.
Now, if I'm on the phone kind of screening one company versus another, other than, you know, profit, non-profit, longevity, and word of mouth, what other kinds of things should I be asking?
I would like to know their health aides. What is their limit on visits?
And why is that important?
That's the person who's going to actually lay hands on your loved one to do the personal care, that bath, wash their hair. Even if they're bedridden, they can get in there and comfortably, without causing them distress, wash their hair for them, shave them, change their clothes, their bed. That's critical for somebody to feel good. I know right now our health aides, if somebody wants them, because you can always say no, but if they want them, they're available from anywhere 1, 4, 5 times a week to see your loved one.
Oh, wow.
Yeah, that I don't hear that out there very often. That there's that much availability. So you want to know that's an option if you need it. So I'd want to know that. I would want to know your nursing staff. What kind of longevity do you have? And what is their caseload? How many patients does each of your nurses averagely care for at a time? That
What is
varies
that
greatly.
With you guys, what does that look like?
That can be, usually we would love to say we're about 13 tops a nurse. You know, once in a while you'll go over it a little at a time. It may be a short time, then it comes right back down. And the reason being is, and that has nothing to do with how many patients we're caring for. You hire more staff. If that nurse is that overwhelmed, how long is she staying in that home with your loved one? How present is she? Because if she's carrying a heavy load, she's already in her head thinking, I gotta go, I'm gonna fall behind, I have to go. That's not a visit we want to encourage. We want her to be able to be present and be there for her patient and her families.
Right.
So you want a low caseload.
Good.
Yeah.
Any other questions that we should be asking?
Oh, I always interrogate everybody when I go. I'd like to know when I call in, who am I speaking to when I call your company at midnight? Am I getting a receptionist, which I have to leave a message for? Or am I getting a registered nurse on that phone when you call at midnight? Or do I have to leave a voice message?
That's a good one.
And I was very shocked. Not so long ago, we had somebody switch from one company over to ours, and their number one reason was every time they called, it was an answering service.
Wow.
Yep. And that's not acceptable in hospice. If you call our company 24 hours a day, it will always be answered by a registered nurse.
Right. Yeah. Thank you for that.
You're welcome.
So Krista, do you have anything or anything else, Angela, that you would think is important to our Facebook friends?
You know, one thing I want to put out there for families, we always wait for our doctor to tell us when it's time for hospice. Unfortunately, a lot of physicians, I'll say, it's not a conversation they're any better at giving than we are at asking for it. So I encourage you, when that voice inside your head and in your heart starts to say, I think we need to start looking at something else. We need to know where we're really at. Make that call. It doesn't mean you're committing yourself to anything. You're just gathering more knowledge, and that can only benefit everybody.
Right.
Yeah. So thank you, Angela. We appreciate it. And I did put up Hospice of Michigan, Angela's location that she is out of up here on the screen and the phone number. So if you or a loved one is thinking about hospice and want to call and talk further, like Angela has suggested, you can do that. And somebody there will absolutely help you. And then, of course, if you are looking for home care or care advocacy, you can call us here. We're in Utica and our phone number is up on the screen. We would love to help you, and your loved one in home remain safe. And, even if they are on hospice, sometimes, like Angela said, you need somebody like us to come in as that extra help to come in and provide care for your loved ones. So thank you again, Angela. Misty, do you have anything else?
No, thank you. Hope everybody has a great weekend.
Thank you for joining us.
Thank
All right.
you.
Bye-bye.
Bye. Bye, Krista.
Bye, Angela. Thank
Bye.
you.
Oh, no.